I'm delighted to participate in this symposium. We are going to review the data, but focus on 3 clinical cases to illustrate some of the challenges we are facing in daily practice. But before discussing the cases, I would like to spend a couple of minutes reviewing the recently published IHA treatment guidelines, because I think they somehow captured many of the changes that have occurred in the field over the last few years. Yeah, I think the first important message is actually what has not changed. So treatment initiation should still be based exclusively on either CLL criteria. Even in 2026, we should not initiate treatment solely because of the presence of adverse biological features such as TP53 aberrations or complex karyotype or mutated GHB. So the watch and wait strategy remains appropriate until patients develop what is called an active disease. So there are, when the patient requires therapy, there are several key factors that you have to consider. The first one is the TP53 genetic status. So you see here in this algorithm where the patients with this genetic abnormality are proposed to be treated by continuous therapy, and below that, the fixed duration combinations. So the next factor that you have to consider is the mutational GHB status. The role of GHB is now less dominant than it was during chemoimmunotherapy era, but is still providing an important prognostic information for our patients. And again, I think one of the important, as Farrukh was mentioning, one of the important changes in this new guidelines is that we are moving towards fixed duration combinations in mutated or unmutated GHB patients. And below that, we have the BTK inhibitors. So I think the trend now is to go for fixed duration because we are saving toxicity, we're saving resistance, we are also saving cost for the system. So this is, I think, is one of the important messages of this guideline. So I like these guidelines because one of the important things is that it recognizes that there are often more than one correct answer for every situation. So the recommendation, as was said before, should be based in many patient factors, not only the efficacy of the therapy, but also the situation of the patient, comorbidities, treatment goals, logistical considerations, and so on. So with this framework, let's move to the first case. This is our first patient. It's a 58 years old female with a classical CLL with active disease, progressive lymphadenopathies, splenomegaly, short lymphocyte doubling time. She had anemia, slight anemia, but thrombocytopenia, and mutational status showed that it was unmutated GHB, TP53 deleted, and p53 mutated with a BAF of 45% that suggests heterozygous deletion of the genome. So the renal function was normal, and that was negative. So the first question for that patient, this is the female, 8 years old, with a high risk genetic features. You can give continuous BTK plus obinutuzumab, fixed duration BTKI plus venetoclax, plus minus anti-CD20, fixed duration MRD-guided BTKI plus venetoclax or FCR. So, you are voting for a fixed duration BTKI. Interesting. Despite the guidelines that we were saying that the recommendation was a continuous BTKI, you're proposing a fixed duration BTKI, which is very interesting because I think in these young patients, I think we have to move the field to fixed duration combinations, combining BTKI plus venetoclax plus minus anti-CD20. I think everybody is starting to use, particularly in these young patients, just to spare the continuous therapy for the whole life. Okay, so let's move to the second part of the guidelines, I think. Yeah, that has been covered by Farrukh. So you can see here the different sequencing strategies in patients that are relapsed refractory CLL. Maybe I will focus on those that were treated with covalent BTKI. And then we have to consider in those patients the reason for discontinuing, toxicity, or progression. So in patients that discontinue because of toxicity, we have the opportunity to switch to another covalent BTKI or move to fixed duration venetoclax rituximab or use pirtobrutinib. In patients progressing to a covalent BTKI, we have now the option to use venetoclax plus anti-CD20 or pirtobrutinib. Another box that is very interesting is those patients that are considered double refractory to this covalent or BCL2 inhibitors. And then those patients, we can use pirtobrutinib, lysocell, retreatment with venetoclax and anti-CD20, or I would not recommend to use the PI3 kinase delta inhibitor, but there's still option to use this drug. I think we should move to the second case. Is a male, 78 years old, with a history of, again, CLL with high-risk genetic features, mutated TP53, complex karyotype with 5 abnormalities, and unmutated GHB. He started ibrutinib, developed cytopenias, and discontinued ibrutinib after 5 months due to significant muscle and arthritis. So after stopping ibrutinib, the lymph nodes start to increase, inducing pain. So he subsequently started a combination of venetoclax rituximab. He completed the 2-year course and remained without requiring therapy for more than 3 years. But again, the patient progressed and requires a therapy. So it comes to the next question. So this is a patient, high-risk genetic features that was treated with ibrutinib and then venetoclax rituximab, and is progressing after 3 years of venetoclax rituximab. These are the options: Acala, Zanu, pirtobrutinib, retreatment with venetoclax anti-CD20, or CAR-T. Remember, the patient is 78 years old. So your choice is pirtobrutinib, which is, I think it's an excellent option. It could be the patient in some places where you don't have access to pirtobrutinib, you can still retreat the patient with a second generation BTKI because the patient was just intolerant to ibrutinib. So you can try to switch to a BTKI, but I think pirtobrutinib is a good option, and it's also a good option to drive venetoclax anti-CD20, but we know that venetoclax rituximab in these patients with high-risk features is not effective. And CAR-T therapy, 78 years old, maybe is too old for a CLL and a CAR-T. This is our last case. Again, is a 63 years old male with high-risk features. All the cases have high-risk features that's including, again, as a deletion 17p and mutated GHB. Progressed, treated with acalabrutinib, a second-generation BTKI, and 1.5 years after starting the therapy, the patient was progressing on acalabrutinib, and he transitioned to venetoclax rituximab. And importantly, there was no, so the acalabrutinib was not stopped. So there was an overlapping with acalabrutinib and venetoclax rituximab because you're risking a flare when you stop acalabrutinib in those patients. So the patient was 15 months into treatment with venetoclax rituximab and developed diffuse lymphadenopathy, and the PET CT scan was suggested of CLL, so the SUV max was kind of low, So there was no signs of histologic transformation. So I think we have here high-risk genetic features, young, 63 years old, that was refractory to acalabrutinib and refractory to venetoclax rituximab. So the options are similar to the previous one. So you can treat your patient with ibrutinib, Zano, Pirto, retreatment with venetoclax anti-CD20, or CAR T cell therapy. Yeah, I think it's the right option, pirtobrutinib, to control the disease. Perhaps you can plan the use of pirtobrutinib as a bridge for cell therapy like CAR T, or in some places allogeneic cell transplantation. The patient is young, double refractory, high risk genetic features. So the perspective of this patient to be controlled just with Pirto is kind of short. Maybe could be an excellent bridge for the cell therapy. And I have a few questions for our faculty that you can debate or answer the questions. So, Susan, what are the factors that are driving treatment selection in your clinical practice?
Usually I prefer fixed duration therapy for all of the reasons that, were elaborated on during this conference. And it's less likely to lead to resistance. For one, you have time off therapy, no toxicity while you're off, less expensive in the long run, et cetera, et cetera. But the one group where I still like continuous therapy are patients with P53 aberrations. And so those are patients that I still will treat with continuous therapy. Whether that will change as time goes on, we get more data on the combinations, I don't know, but right now that's still my go-to for that group.
And how do you choose the therapy? Do you talk to the patient? You consider what's
Well, I mean, obviously I talk to the patient and they have to agree to it. And I do tell them that there's fixed duration that can be an option, but that, with this high risk disease, and I could see either argument. In my mind, keeping the clone suppressed longer is better, but you could also, I suppose, make the argument that, you're going to, just like with continuous BTK in non-17p, you may lead to other mutations over time. Certainly their remissions with fixed duration therapy are shorter, but even with venetoclax obinutuzumab, they got 4 years, which is not bad. So I definitely like continuous therapy in that group, but I can see, I don't think there's any wrong answer, is what I'm saying. So if the patient really wanted fixed duration, I'd be willing to go in that direction.
So Farrukh, do you still go for a fixed duration or continuous, and which scheme of fixed duration is your favorite? Because venetoclax ibrutinib is not used in the United States as opposed to Europe.
But acalaven can be used.
Yes. Yeah. And in the last few months, I have noticed that I've changed my practice to AV, and then in the appropriate patients have a discussion about AVO. How will that change as we have access to zanubrutinib and venetoclax, or zanubrutinib and sonrotoclax, for example? I'm not sure, but right now I am talking about A plus V or A plus V plus O, depending on the patient preference in logistics for the most part, and young and old and infectious issues in history. And then do I feel, which is another debate that we can have right now, I guess. But the other debate that is in my mind, at least, is do I stop at 12 months or do I do an MRD kind of approach? And I don't know the answer to that, because I have seen patients who deepen their MRD even after discontinuation of the doublet at 12 months, for example. And then patients who are obinutuzumab treated patients, yes, they will go into MRD 6 negative or MRD 4 negative for sure in the peripheral blood, but that's not necessarily true in the bone marrow or lymph nodes or spleen, for example. So so those are still debates in my mind about what is the optimal duration of treatment. So I like the flare approach, or I like the sequoia approach, but it's more complicated to make it easy to follow. So I feel that 12 or 24, that kind of option would be much easier for widespread use rather than MRD guided approach and adapting treatment, because at least in the US, MRD measurement is not done routinely because we don't do the baselines testing. So we don't have any way to track MRD6, and the access to MRD4 by flow is not very easy.
Okay, so the first case that we were discussing was a young lady with requiring frontline therapy and P53. All the guidelines are recommending continuous therapy. What's your approach in that situation?
Yeah, so I agree with what Susan said about continuing the BTK beyond the 12 months of doublet is what I would do off trial. Obviously, if there's a trial, then that's a separate debate. I don't know if there's enough evidence to add obinutuzumab, although that can be an option, at least from the Elevate TN study. The addition of obinutuzumab did not show improvement in outcomes with the addition of obinutuzumab to BTK inhibitor, and both in the Sequoia and the Sequoia study primarily, zanubrutinib plus venetoclax was very effective for those patients. So if you extrapolate that to A plus V, there's no reason to expect that A plus V should not work. So even though there's no evidence that A plus V has never been used in TEL17P, that's where the guidelines are. Therefore, and that was the same issue with the NCCN guideline, is in the absence of any evidence, we cannot support the use of A plus V. But even if we cannot support the use of A plus V, we know from Z plus V that it's a very effective approach. I don't stop the BTK beyond whatever my initial doublet is.
What about you, Gilles? I know that you are more solid in the solid field, but
It depends what you call the solid field. I like this liquid lymphoma. I like the solid lymphoma, but I like the liquid lymphomas too. I think, if you are talking about the patient you mentioned, I think clearly, the data that were presented at ASH, also with the update of German group's trial, to me still show that BTK inhibitors remains the option in this patient. So whether you use a single agent, which is the guidelines, or whether you use a combination. As you know, we have had several programs for TP53 mutated patients with duration assessed based upon MRD results. We haven't necessarily integrated those in the practice, but eventually we can try to use the same combination of drug, which I remind you is obinutuzumab, zanu, and venetoclax. For this patient, we'll be starting very soon. We have completed, the same study with obinutuzumab, zanu, and sonrotoclax. So I think my feeling is that either this patient is very young, and I will say probably will try to do a doublet, and probably I will also like to continue. How long will I like to continue? I don't know. And I think that's probably a debate that is evidently is that based on MRD, I think we can still use in the US adaptive rather easily, but I know it's not necessarily the case in Europe outside of specialized academic centers. So I will argue for a combination rather than a single agent, especially in these young patients. Maybe the situation will be different if the patient will have been 78 and a little bit more complex to monitor or living from the hospital.
Okay, thank you. Another question is where to place the non-covalent BTKIs, because it's a fantastic drug, very well tolerated. Do we have to use covalent, then venetoclax combinations, and spare the pirto in third line, or move forward the pirtobrutinib? Susan, What do you think?
So it's difficult because the safety profile of Perto really looks good, and I think it does look better than the second generation BTKI.
Yeah.
But we know, number one, that if a patient can tolerate a covalent BTKI, they can get very, very long remissions. I mean, remember on Resonate 2, the median PFS was like 9 years. So somebody's, and that was ibrutinib, but I think it's reasonable to extrapolate to the others that you can get very long remissions. That doesn't mean you can't get long remissions with Perto, but of course we know you can use Perto after the covalent inhibitors, and what we don't know is can you use covalent inhibitors after Perto? So, or will using Perto first, then knock out covalent inhibitors as an option? All of these unknowns are an issue. I think for me, where I might consider using it upfront right now is a really older patient where I'm not worried about sequencing. So in fact, I had one the other day who is 90 years old. I don't have many of them, but a few, probably everybody does. And he finally needed therapy. I put it off as long as I can. And I thought, well, now this is the kind of patient I would probably go straight to Perto. I'm not worried about what he's going to need second line. But I think in patients who are not that old, maybe I'd go even in an 80-year-old, for example, I might be willing to do Perto first line. Depends what your cut point is for where you think maybe I'm not going to need a second therapy. But if I think I am going to need a second therapy or I have a much younger patient, I would be doing fixed duration anyway. I wouldn't be doing continuous BTKI. So.
Okay, fully agree. What about you, Farrukh? We have 1 minute left for this important question.
So I agree completely. I think if there's a time-limited option with pirtobrutinib, the fact that almost 50%, 40 to 50% of the patients will end up stopping the continuous BTK inhibitor at some point in time. So that makes me go towards a better tolerated BTK inhibitor. But I do also like the security of having access to this drug for younger patients when I know that they truly need it. And pirtobrutinib is my perfect bridge to CAR T, like you discussed in the third patient. That patient is the classic patient that I would take, double refractory, progressing on venetoclax or rituximab. I don't stop the venetoclax. I add the Perto, take them straight to CAR T, because that gives me the confidence that I can salvage those patients and transition directly to CAR T.